In this video, we're going to be talking about a few pointers while taking a history in a case of postmenopausal bleed. Whenever a woman comes to you with postmenopausal bleed, always keep a few differential diagnoses in mind, especially the malignancies of endometrium and cervix and other causes such as endometrial hyperplasia, atrophic vaginitis cervicitis, atrophic endometritis. Local malignancies like vulval and vaginal carcinoma should be kept in mind. And very rarely it will be a foreign body such as a forgotten IUCD or a pessary or prolapse with a decubitus ulcer with secondary infection. Coming to the demographic details, age of the patient is significant because endometrial carcinoma is more common in the perimenopausal age group, whereas cervical CA has more of a bimodal age distribution. Socioeconomic status and occupation is significant such that cervical CA is more common in the lower socioeconomic status, whereas endometrial hyperplasia, endometrial carcinoma is more associated with a higher socioeconomic status because of its association with obesity and other related metabolic diseases. Whenever she presents with postmenopausal bleed, find out it's lasting from how long, does she need to change a pad, or is it just PV spotting? If there's presence of clots, it indicates a large volume of blood loss. Most importantly, don't forget to ask the history of postcoital bleed. Postcoital bleed indicates a local pathology, more importantly pointing towards carcinoma cervix. It points towards presence of a polyp or local lesions such as in case of vulvar carcinoma or vaginal carcinoma. What about white discharge per vagina? It can be present if there is a fungating growth or an ulcerative growth which has undergone secondary infection, and hence the white discharge, sometimes which can be blood stained, more common with carcinoma cervix than with endometrial CA. Weight loss and loss of appetite, it indicates towards malignancy. What happens when postmenopausal bleed presents with mass per abdomen? Which are the conditions? Whether in history there is mass per abdomen or on examination if there is mass per abdomen, you should think of always three differentials. A granulosa cell tumor, which is an estrogen producing ovarian tumor leading to endometrial hyperplasia, which is the cause for postmenopausal bleed. Presence of ascites, the patient might not be able to distinguish the presence of ascites or a mass abdomen, hence ascites may be associated with any pelvic malignancy. Whenever there is a obstructing cervical growth or an endometrial growth which is causing obstruction to the flow from the uterine cavity, that can present with pyometra. Pyometra has other features such as fever and pain abdomen too. Mass PV presenting with postmenopausal bleed, it can be a polyp, a local growth, or it can be very rarely it can be a long-standing prolapsed uterus with the decubitus ulcer which has undergone secondary infection and hence now presenting with postmenopausal spotting. History of fever suggests an undergoing inflammation. Urinary symptoms are very rare but can occur, especially if there is a cervical growth or endometrial growth which is extending laterally into the pelvic wall and hence causing kinking of the ureter, leading to reflux, hydroureteronephrosis, leading to decreased urine output. Pain abdomen, it might be because of infiltration of the nerves or the growth extending into the surrounding tissue, or it might be just an inflammatory reaction. Pedal edema, it is usually associated whenever there is spread to the lymphatic drainage. Obstruction to the lymphatic outflow can present with pedal edema. Menstrual history is very important in a case of postmenopausal bleed. Early age of menarche in late menopause indicates a long duration of exposure to estrogen and hence more in favor of endometrial hyperplasia or endometrial carcinoma. What if the history was suggestive that previous cycles, that is before she attained menopause, if the cycles were anovulatory? At that time, it goes more in favor of the fact that there was unopposed estrogen activity for a long time and hence endometrial hyperplasia or carcinoma can be a possibility. High parity is seen or is a risk factor for carcinoma cervix, whereas low parity or nulliparous, then because there is no intervals of prolonged progesterone exposure, hence there is unopposed estrogen activity for a long duration favoring endometrial hyperplasia and hence carcinoma. So low parity, high parity, both are risk factors for two different malignancies. Was there any use of contraception or any hormonal pills? Unopposed estrogen activity is again a risk factor. Previous long-standing medical disorders like hypertension or diabetes are usually associated with other metabolic syndrome disorders and hence presenting with unopposed estrogen activity leading to endometrial hyperplasia. Previous history of surgery. What surgeries are we talking about? Previous history of pelvic malignancy surgeries or any other malignancies. Breast CA. If the patient has been operated for breast carcinoma and if the patient is on drugs like clomiphene citrate, tamoxifen citrate, they are high risk factors which lead to endometrial hyperplasia. What other medications are we looking for? If the patient is on anticoagulants like warfarin or low molecular weight heparin, if she is on aspirin, there might be some chances of postmenopausal bleed. Very unlikely though, that should not be the first thing in your mind, but it can be considered. You're asking about history of asthma just if you're considering surgery in mind. PCOS and other medical disorders, mainly you want to rule out for unopposed estrogen activity. Familial history of malignancies. What malignancies are you going to ask about? Especially the pelvic malignancies, ovarian, endometrial, carcinoma cervix. More likely to be ovarian and endometrial have a hereditary concept than carcinoma cervix. GI malignancies might now present with endometrial CA or ovarian CA. Breast carcinoma, all the malignancies history should be asked in the first degree or second degree female relatives of the patient. Personal history of bowel and bladder habits is significant for further management. These are just a few questions you're going to ask while evaluating a patient of postmenopausal bleed. Hope it was useful. Thank you for watching.